All right. Well, hello, everyone. My name is Alina Smith, and I work for PICA, which is the Platform for International Cooperation and Undocumented Migrants. And it's really my pleasure to welcome you today on behalf of the co-organizers of our webinar today. PICA, together with Human Rights Watch, the European Public Health Alliance, and Médecins Monde. We're very happy to have you join us today for our discussion about vaccine equity. COVID-19 vaccine equity. So in the European context, at least, we're fortunate that, as we reach the end of June, generally speaking, member states are well on their way in terms of distribution of the COVID-19 vaccines. And so what we want to do today with our discussion is to pause and to really look closely at the populations that perhaps are not being reached by vaccination efforts at the national level, and also at some of the efforts to actually try and reach them. And so we know that vaccine equity under the WHO guidelines from the end of last year is and should be the centerpiece or the driving principle, both in terms of global vaccine equity, but also national vaccine equity, in terms of really orienting and driving national programs. And we know that even the the European Commission's communication from last October really also made a point of emphasizing that equitable and affordable access to the COVID-19 vaccines for all would be an important priority. So today we want to take a specific look at what the situation is in terms of two particular populations. So on the one hand, people in situations of homelessness, and on the other hand, people who are undocumented. And of course, in some contexts, there are overlaps in between those groups. So we are really fortunate to have a wonderful group of speakers with us today. We have two panels. The first panel is going to give us some insight on what is actually the state of play. So what is the evidence of what's actually happening at the national level in terms of the realities around access and barriers that are confronted by these groups. And our second panel will take a look at what are some ideas for actions and the way forward in terms of what member states can do, and also in terms of what the European Union can do to really promote a more equitable distribution and access to the COVID-19 vaccines. So I'm really happy then to kick off this opening panel and to introduce our first speaker. Our first speaker is Belkis Willy. Belkis is a researcher at Human Rights Watch, and Belkis is going to present findings of some work that she's done over the last months, looking at the situation in 8 different countries around barriers to accessing the COVID-19 vaccines, looking specifically at registration processes. So the most basic process of all is just signing up for the vaccine. And what have these processes what is the reality in terms of access to the vaccine for these groups? So Belkis, I turn it over to you.
Thank you so much. It's lovely to be virtually speaking to everyone today and working with organizations that are trying to promote and ensure equitable access to the COVID-19 vaccine across Europe and beyond. For the research that we've been doing at Human Rights Watch, we've been looking at COVID-19 vaccine access for marginalized groups in 7 specific EU countries, as well as in the United Kingdom, which I won't be delving into today. And today I'll really focus on France, Germany, Greece, Italy, Poland, Spain, and Hungary. In most of these countries, 2 main issues are cropping up and causing barriers for undocumented migrants and homeless people to access the vaccine. One is requirements of documentation, and the other is a lack of a firewall of information between healthcare workers and immigration services. It's important to note at the outset that these are not the only marginalized groups who may be facing access barriers, and nor are these the only barriers that people are facing, but instead the ones that we've chosen to focus on. It's also important to note at the outset that vaccine access has in many countries matched broader access to healthcare. So countries that are providing universal healthcare, including to undocumented migrants, are generally doing a better job of ensuring vaccine access. So in other words, one can't examine vaccine access without acknowledging that this is part of a bigger picture around healthcare access. But for this this research, we've really restricted ourselves to looking at COVID-19 vaccine access, and we will be publishing a report on this topic and on the findings I'm laying out now in the coming weeks. So all of the countries that we're looking at are currently vaccinating all adults, with the exception of Spain, which at the national level is vaccinating all adults above 40. And in each of these countries, at least 25% of the population has already been fully vaccinated. The first country we looked at is Germany, but I will leave that to one of my colleagues on the panel, Dr. Offe, who can cover the situation in much more detail than me. But just to say that in Germany, barriers have stemmed from both documentation requirements and from the lack of an immigration firewall. In Greece, Greek nationals and some residents with a social security number can register for the vaccine. Most migrants do not have a social security number anymore. This has been a change in legislation over the past few years. And now this requires that migrants get access to a different number. It's a temporary insurance and healthcare number, but this process of getting access to that number is largely inaccessible, including because of documentation requirements, language requirements, and that it's tied to one's asylum process. So the government in March announced that people without either a social security number or this temporary healthcare number could apply for yet another card, a different number, a temporary social security number known as the PAMCA. In order to access the vaccine. But this has yet to be operationalized as a system. And from what we understand of what would be required to sign up for it, undocumented individuals would not be able to have access. And I want to point out that in Greece, there have been previous vaccine campaigns in camps for asylum seekers that have not required people to have social security numbers. Now, in March, the government also created a technical sub-working group headed by the Ministry of Health. UN agencies and non-governmental organizations are a part of it. And it's their job to sort of design a comprehensive vaccine campaign that will ensure that all migrants have access, but they have yet to finalize plans. And separately, the government very recently started vaccinating people in camps. But we've heard from 3 NGOs in the last weeks that people who have been rejected for a second time in their asylum claim are actually being rejected from getting access to the vaccine. In Italy, without a valid long-term visa or residency permit, people are de facto excluded in most cases. The Italian government had articulated exceptions to its documentation requirements of a tax code and a health card number, which you need in order to register for the vaccine online or by phone. But in reality, based on those we've interviewed, without those 2 numbers, you simply can't sign up. There was an initial government document, a Q&A, that was laying out how people could register without these numbers. And it said that they could get some kind of reference document substantiating their personal details, but that language has actually been removed from the online document, and people seem to be facing this barrier. We have seen some NGO initiatives, particularly in the city of Torino, where NGOs have been working with local healthcare officials to dispatch vaccine centers that are mobile in order to reach communities that are not getting serviced, and they're able to forego the documentation requirements. In Poland, individuals need an identity number in order to register for the vaccine. Now, separately, if you don't have an identity number, you're able to register with a doctor or a medical facility, but the government has put out no information on what kind of documents would be required by, for example, a medical facility to register someone. In late April, a Ministry of Health spokesperson said that any migrant could get vaccinated if they went with their passport to a doctor's office. But of course, for undocumented individuals without a passport, that will be a barrier. And in addition, in Poland, there's no firewall between healthcare and immigration services. And the law actually requires that authorities cooperate, as the law puts it, cooperate with the border police. And the government has put out no information whatsoever on what kind of information would be shared from the healthcare context, and including particularly when people are registering for the vaccine, what information would get shared with immigration officials. In Spain, everyone is guaranteed free healthcare under national law, but the issue is really at the local level in the autonomous regions, where some autonomous regions require that someone has been registered with the municipality for 90 days before issuing them with a health card. They require sometimes things like a valid identity document, a housing contract, an amenities bill, in order to register that individual to issue them a health card number. And that really is a barrier, including for undocumented migrants, seasonal workers, and homeless. And since 2012, people who enter Spain for family reunification purposes are actually completely cut out of the healthcare system. In a positive development in some areas, including in Asturias, the Balearic Islands, and Valencia, you've actually had local authorities starting to take measures to vaccinate people who are not enrolled in the healthcare system, including who entered because of family reunification purposes. In France, there are currently no documentation requirements, but actually it seems to be an issue of bad information. So we know from Doctors of the World that some people have called the government hotline asking what documents they need and have been told that they're required to present, for example, identity documents or a health card number. And in fact, we've found online major media sites with information about access to the vaccine that are saying the same thing. In Hungary, the last country we looked at, our understanding, which is not entirely clear because the government has put out such limited information, is that only people with a social security number or a valid residency can access the vaccine. And the system set up in Hungary is one that relies on general practitioners to match individuals who register online with vaccine locations that are near the office of the general practitioner. Now, this system may be excluding undocumented people. The government hasn't clarified how they assess a residency status through the online system. And in addition, people who are not registered with a GP or whose GP office is closed, something currently the case in some areas of Hungary, or if a GP is located in another city, someone maybe moved in the past few years and has not re-registered with a new GP, they might get an appointment in a city so far from them that they're not able to go and get access to the vaccine. In Hungary, another considerably large issue is misinformation about the vaccine, and that's particularly rampant in the Roma community. And the Roma groups that we've interviewed have told us that the government has done very little to combat misinformation, including on social media platforms, about the vaccine itself. And finally, in Hungary, people are required to present an address card. This is a government-issued card that verifies one's address in order to get the vaccine and in order to receive an immunity card afterwards. And that is a real barrier for certain communities, including homeless and including particularly within the Roma community. Now, what we're calling for, based on all of this research that we've done, is for governments to eliminate documentation requirements so long as these documents are not needed for legitimate vaccination purposes. For example, establishing that someone is, let's say, over 65 and falls into a prioritized group at a time when only prioritized individuals are getting access to the vaccine. And states need to ensure that the registration process is accessible to all segments of the population, including older people, people with disabilities, and other marginalized communities without or with limited access to the internet or low digital literacy. This is an issue particularly of concern in Hungary, where the entire system is online only, and where particularly the Roma community has limited access to the internet or lower digital literacy. States should also ensure vaccination efforts are completely firewalled from immigration enforcement activities, and that they take steps to communicate this with the public. And we're calling for national human rights institutions within the countries we've looked at to actually be a part of the monitoring and reporting on equitable access to the vaccine. I'll end now with just a few comments more directed towards the EU level and EU institutions. We're calling on the European Commission to urgently provide provide guidelines to member states on how to meet its key objective laid out in its vaccine strategy, which was ensuring equitable and affordable access for all in the EU to an affordable vaccine as early as possible. And we're calling on the Commission to request guidance from the European Agency of Fundamental Rights in developing these guidelines, and to create fora in which countries can start to exchange the better practices that we've seen around vaccine equity. We're calling for the European Centre for Disease Prevention and Control to build on its call for equitable vaccine access and its mapping of vaccine access issues for migrants in Europe, and to issue operational guidelines on better practices to ensure equitable vaccine access, with a specific focus on eliminating barriers to registration. And it should carry out country-level engagement to encourage the adoption of these operational guidelines. And finally, the European Commission should also allocate EU COVID-19 related funding to support multi-language and multi-platform vaccination information campaigns to target the groups that are struggling to register for the vaccine, including those that I've covered today, undocumented migrants and homeless people.
Thank you so much, Balkis, for that very, very helpful overview. Providing some really, really concrete insights on the situation in practice and really concrete suggestions about the way forward. And I think it's really interesting and important that you've not only mentioned health bodies like the ECDC, but also human rights bodies being part of the monitoring of issues around equity. I just wanted to note that there are some comments in the chat providing some updates as of this week, actually, on the situation in Greece. So thank you for that. And I didn't say it at the outset, but indeed, you are all participants most welcome to put comments and questions in the chat. And we will have a chance for Q&A at the end of the first panel and also for the second panel. So thank you again, Belkis. And we're now going to turn to a country-specific example. We're going to hear from Dr. Johanna Offa from Médecins du Monde, Doctors of the World in Germany, who is going to share with us her experience and insights on the situation for undocumented people and people who are homeless in Germany in terms of access to the COVID-19 vaccines. Please, the floor is yours, Johanna.
Thank you very much, Alina. Thanks for the invitation. I'm very happy to be here. Let me try to share my screen. I hope you can see my presentation now. I will give a brief overview on the barriers to access COVID-19 vaccinations for homeless people and undocumented migrants in Germany. To start, let me say a few words on MDM Germany. Besides international humanitarian projects, MDM Germany, in cooperation with partners, carries out domestic projects providing medical services and social support to people with limited or no access to healthcare. We are active in 4 cities in Germany. The services are provided free of charge and anonymous if wanted, and we combine this service provision with advocacy on the human right to access healthcare as a state duty in order to eventually make our work obsolete. The majority of our clients are undocumented third country nationals and unemployed mobile EU citizens without residence right. 88% of our clients are homeless. In order to understand access to COVID-19 vaccinations, it is necessary to briefly look at the overall access to healthcare for these 2 groups, as Belkis already mentioned. I start with undocumented migrants. While they do have legal entitlement to access healthcare services in case of acute illness and pain, the problem is really reporting, or the firewall, the missing firewall. All public authorities are obliged to report a person without legal residence to the immigration office or directly to the police. This includes the social service departments, which are responsible for covering the cost of health services. So if this person we see on the screen wants to go to a doctor, he would have to go to the social service department first, and the officials would report him to the immigration department or directly to the police, which would then deport the person. Thus, not surprisingly, undocumented migrants avoid medical care. While there is an exception for emergency care, this is very limited and does not work properly. Access to healthcare for homeless is also often limited. Many homeless persons do have a health insurance, but many haven't paid their contributions for some time, so that they are only entitled to limited health services. And to make the situation worse, there's a new law that regulates that health insurances end completely if people do not pay their contributions and cannot be contacted by the health insurance. Of course, that is the case for many homeless people. Many of our homeless clients are unemployed EU citizens, and they, since 2016, do not have any entitlement to health services in Germany. And of course, other barriers exist, language discrimination, and many have fear going to the doctor or are embarrassed. This situation of lacking integration into the healthcare system is important to understand as a starting point for today's discussion on access to COVID-19 vaccination. The lacking access to healthcare makes these population groups more important to reach, as undiagnosed and untreated chronic diseases put them at higher risk of severe consequences of an infection. It also makes them harder to reach if they are not connected to general practitioners for information and motivation, and they usually mistrust and fear the healthcare system. Both issues should lead to a prioritization in vaccination strategies, as has been recommended by WHO, the EU Council Bioethic Committee, and the Red Cross EU office. So what is the legal situation for homeless and undocumented migrants for accessing vaccinations in Germany? The vaccine regulation defines that those with habitual residence or registered address in Germany are entitled to access vaccinations. This leaves many people without a registered address, which you can only get when you have an apartment, a rented apartment, in uncertainty whether they would be eligible. In March 2021, people living and working in homeless accommodations were also prioritized. In April 2021, the Ministry of Health clarified in response to a parliamentary question by the Green Party that undocumented migrants are also entitled to vaccinations, but they are not prioritized. Vaccination is free of cost, but there's no exception to the duty to report for public authorities that are sometimes involved, for example, for cost coverage. And in the doctor's office, you usually have to show your health insurance card. So in practice, access to vaccination is hampered by a number of barriers. For one, administrative barriers exist, as only those with habitual residence are entitled to vaccinations. A proof is usually necessary, and without a registered address, this is quite difficult. Also, in the beginning, prioritized groups were often contacted via their registered address. They got a letter. So there was no possibility for priority groups, for example, undocumented migrants above the age of 80, to get vaccinated if they did not have a registered address. Also, in the whole process of getting vaccinated, you need to have an ID to register for a vaccination date, to enter the vaccination center to get the second vaccination, and to get a digital vaccination certificate. There are also other barriers. Homeless people and undocumented migrants are often not linked to the regular health system and cannot be easily contacted. They have a high level of fear and mistrust towards any official site and are thus hesitant to get vaccinated. And there is a very low level of information and little outreach that is really adapted to the needs. In addition, there's a language barrier and also an alphabetization barrier. And last but not least, these population groups both experience high levels of discrimination in the health sector. Throughout Germany, cities have recognized the problem that these population groups cannot be easily reached, but at the same time highly vulnerable. I'll give two examples. The city of Munich has developed approaches to vaccinate those hard to reach. They have mobile vaccination teams in hotspots, and they have special vaccination dates in the vaccination centers for homeless. And they do vaccination at or by civil society service providers. There's also a written confirmation by the city's health department that undocumented migrants do not have to fear reporting when they get vaccinated. This is a bit unclear because public authorities are obliged to do so, but can create a bit of trust. And a confirmation letter for habitual residents that we and other civil society organizations can write is easily accepted. The city also offers hotel rooms for people experiencing vaccination reactions and that do not have a place to rest, which is very important. And Médecins, Monde is involved in the program and provides information for clients, refers to vaccination centers and doctors, and carries out vaccinations. We ourselves did 55 in the past weeks. And we have made the experience that if we inform and motivate our patients that trust us, the willingness to get vaccinated is much higher. In Berlin, the local government has organized that mobile vaccination teams vaccinate homeless people in 20 service sites. Here, vaccination was also possible without documentation very easily. That was interrupted with a change in AstraZeneca recommendation, but there were, until end of May 2,278 homeless people vaccinated. And Berlin has also involved civil society health service providers in the vaccination, including our cooperation project with Medizin hilft in Berlin. Okay, finally, these kind of approaches also exist in other major cities. I just chose these two, but there are other very good examples, very successful. In conclusion, our recommendations are that these hard-to-reach population groups are prioritized in the national vaccination strategies, and that administrative barriers are reduced for the sake of all, but also especially for the most vulnerable. And second, that adapted information and outreach is developed in cooperation with civil society and with participatory approaches so that they actually reach the vulnerable groups. And third, the abolishment of the duty to report in the health sector. We urgently need a firewall between the health services and the immigration office. And in general, one last word, the pandemic can show us that undocumented migrants and homeless people are part of the public and public health, even if they are often not visible. Beyond the pandemic, we need to ensure their sustainable access to the regular healthcare system. Thank you very much.
Thank you so much, Hannah, for that really, really insightful presentation. And I think it's very clear that the situation in Germany, the limitations are very much around, as you pointed out, significant administrative challenges, but also this question of trust linked to the absence of a firewall and reporting requirements. We already heard from Belkis about the very significant differences from country to country in terms of their approach, and we see in the German context important differences from city to city, and very nice to hear at least about those promising examples at the city level. We will now turn to the situation in Belgium to hear about a very different approach, a very different context. And we are very, very happy and fortunate to have with us today Karen Metz, who is advisor to Belgium's Minister of Social Affairs and Public Health, who's going to share with us the approach that it's been taken in Belgium to the vaccination, and in particular vaccinating undocumented people and homeless and others in situations of vulnerability. Please, Karen, the floor is yours.
Thanks, Alina, and thanks also to the other colleagues for their really interesting presentations, which brought up a lot of issues that are very recognizable for us as well. I think I'll start by saying that Belgium is a very complex country where very many layers of government are playing a role in the response to COVID and in developing a vaccination strategy. So as the federal government, we play a role, but we do this in cooperation with the regions, with the local municipalities, and of course also with civil society. And it was also civil society playing a role in getting our approach started, because the Migration Agency and several NGOs reached out to us, raising a few obstacles, and from the beginning getting in touch with us saying, how are we going to handle this? We see a number of issues, primarily the issue of registration posing an obstacle for people to get vaccinated. And yes, it is so that normally if you want to get tested or vaccinated, you need an ID. But Belgium also has a different sort of registration, which is called the BIS number, which is actually used usually for people that are not registered in our Belgian government system, but that have a connection with Belgium, that are connected to our social security or our healthcare. And that also required a lot of effort to make people aware of the existence of this number, and also of the requirements for identification in order to get this number, which are quite minimal, because in order to get this number, you need to give your name, I think your place of birth maybe, and your contact, and a contact. No, what is it? Your name. Yes, just your name and a contact address. I think I'm just gonna look it up. I'm a bit confused because I wrote it down. Here, you need your name, your date of birth. Thank you, God. Your name, your date of birth, and a contact address either in Belgium or your place of birth, or a contact address in your country of origin. Those are the three things you need in order to register, which is quite flexible and makes it easy for people to register. So this number has opened up a lot of doors, but of course we also had this issue of confidentiality and firewalls, where there was a lot of distrust among the people we were trying to target in giving out this number, because they were afraid it would be shared with migration authorities and then could possibly lead to removal. So we had another agreement between all levels of government, so also the regions and the national federal government, on data sharing when it comes to the vaccination strategy. And there it was also written in black and white very clearly that all the data collected for vaccination purposes could only be used for health purposes. So that was there in black and white. So we shared this information also with relevant civil society organizations and actors that were reaching out to the people concerned. I think there we could have probably gone a step further in awareness raising, because it was clear that we got a lot of requests for like a formal communication or a formal confirmation that that information would not be shared with immigration authorities. But we felt like this is now written and you can see it. You can see it here. So this also really helped. So with all this information and also with our contacts with through our contacts with organizations on the ground, we tried to develop a set of recommendations, which then were agreed in an interministerial conference. Because we're so complex, we have an interministerial conference where all the ministers of health come together to kind of make decisions about how we deal with COVID and vaccination. So there, we agreed on a set of recommendations, and I'm gonna single out a couple of them, which also can be useful. So first of all, we said everybody needs to work with a localized approach. So depending on where you are, you involve your welfare agencies, your social workers, civil society, etc., in reaching out to the people concerned. And then we sort of went for a three-tiered approach in order to get people vaccinated. And the first level was that we really wanted to get people also to go to the formal vaccination centers. And there we recommended to maybe foresee a time slot when people could go without an appointment, or train one person per vaccination center, so that they were aware on how to deal with this group. I am not sure on how far this has been applied. Then the second level was working with outreach teams, to, depending on where you are, to raise awareness also about vaccination, about where they could go, etc., to get vaccinated, and the several possibilities that existed, the registration possibilities, etc. And then the third level was to really work with mobile vaccination teams. So there are a lot of cities, especially where there's a large concentration of groups that are harder to reach, like Antwerp and Brussels, where they really also worked with just outreach teams. And we've also had a really creative civil society who reached out to churches and mosques and diaspora organizations and worked together with them to set up local kind of vaccination efforts. Another recommendation that we had is that we would work with one-shot vaccines, Johnson & Johnson, which were reserved specifically for this group because it makes it less complex. And then we also, to reach the homeless people, we extended, because normally we have shelter, like emergency shelter for homeless people throughout the winter, which lasts from November till March. And we extended the shelter now until September, so that we can also, which also makes it easier for us to reach this group. So that was also one of the measures that we took in order to reach some people as a collectivity. So I think there, another issue that I failed to mention, which was also important, was who could create, because the registration, who could create this specific identification number. And there also we've been quite flexible. So local government authorities can create this number, but also general practitioners can create this number, but they need to be made aware of that. So that also required some awareness raising, because in rural areas or areas where this group is not so present, doctors just don't know it. And I think a lot of civil society actors also just worked with their target audience, collected all the data necessary, and then transferred it to local authorities, who then inserted it into the system, and then people would be getting their registration numbers, which is kind of, allowing a degree of flexibility in creating these numbers. But we still thought these numbers were important, and this registration is important, especially in times of vaccine scarcity, so that we know that everybody gets just one vaccine. So that was really a key issue. So I think we're getting there step by step, but we're still sorting out some final issues, because now, and this is something I want to raise, and I don't know if the experience has been similar in other contexts, but now there's a travel certificate, and travel is one of the key motivations for people to get vaccinated, also vulnerable groups, also undocumented people. And sometimes there's an extra step required in order to get this travel certificate. So now we're trying to sort out what we can do in order for people to also have access to this. So it's looking at barriers and finding practical ways to resolve them. All right, this was a little bit about the Belgian approach.
Thank you so much, Karen. That's really, really very interesting and helpful. And interesting to hear both about being proactive and providing recommendations, but also leaving a degree of leeway for local authorities to maneuver based on their particular situations. And also just NGOs being proactive in reaching out to the authorities, and the authorities being responsive to that and really working in collaboration. So that's really something encouraging to hear. And I'm really glad you raised the issue of the travel certificate, because I think that's really where everybody's minds are turning now. And it shows the ways in which access to the vaccine is not only a matter of health equity, but it also is a baseline for actually potentially being able to access other things, including mobility thereafter, including certain types of spaces at the local level, and so on and so forth. So I'm really glad you've raised that point as well. So we do have a few minutes now for questions from our participants. One participant did ask about the availability of slides, and we will just confirm with our speakers who have slides if they're amenable to that. I suspect they will be, in which case we'll put it on the event page, which is the EPHA, European Public Health Alliance event page. And so if everyone who would like to can then access it there. Does anyone have any questions they'd like to put in the chat that we can put to any of our panelists? I don't see anything just yet. I'm wondering, maybe while we're waiting then, since we do have a couple of minutes, if anybody still needs to reflect a bit. Okay. We do have one question, and this is for you, Johanna. Did any other cities in Germany besides Munich issue guidance on the firewall?
Yes, thanks for the question. Start my video as well. Well, the current situation is very chaotic in a way. I mean, it's good that all cities go ahead and try to find ways to get access, but there's no collection of all the approaches that there are. At least I don't know of any collection. So I wouldn't know which ones also issued this kind of guidance, unfortunately. And the situation is moving very quickly as well. So we have new examples of promising approaches every day. So I think it will take some time to really look at who did what and with which outcome.
Thanks a lot, Johanna. We have another question about, I guess it's for any of the panelists who would like to come in on this. Has there been any strategy to reach rough sleepers who do not access homeless shelters or homeless service sites? So how are we addressing in the different contexts rough sleepers? Would you like to comment, Johanna, first, maybe?
Yes, I can do so. In the guidelines from the German government, the vaccine regulation, it said in the beginning only homeless accommodations, and there was a lot of protest by homeless service providers saying, well, we also need to prioritize people working and coming into day centers. So that was one opportunity for rough sleepers, and also these mobile vaccination units, of course, target rough sleepers. And then there's also in Berlin, there are vaccination activities for certain quarters of the city that have been particularly infected, and there every homeless people can come and get vaccinated without actually proving that they live there, but they can just go there as well. So these approaches do not only target those that live in some kind of accommodation center, but also rough sleepers. But there we have made the experience that a lot of motivation and information is necessary, but that it is possible, and that people can be motivated to get vaccinated.
Anyone else want to come in and comment on this question?
I know that in Brussels, they work with mobile outreach teams that also try to either raise awareness or vaccinate people that are sleeping in the rough. Thank
you. Maybe we can squeeze in one more question before we turn to the next panel. I'll actually put two questions out there before we wrap up, and anyone can jump in on them. One question is about intersecting identities and whether any of you have insights on, for example, with respect to these groups, are there, for example, is age an additional factor of vulnerability or exclusion, or, for example, gender identity, and so on and so forth. So if you have a comment on that. And then a final question about something that was mentioned, I think it was in your presentation, Johanna, about the vaccine strategy generally reflecting a country's overall policy on healthcare, and are there any countries providing more inclusive access to healthcare than you might expect from the prevailing overall context? Maybe that's a question then for you, Belkis. Does anyone want to jump in very briefly on the intersecting identities point, and or on the more, I think from you, Belkis, on where you see more inclusive approaches than you might otherwise expect?
I'm happy to take that second question first. So there are instances where we're seeing more access to the vaccine than one would see to healthcare. And examples that come to mind of the countries that we've looked at would include Hungary and Poland in that category. So these are countries that have a more restrictive access to healthcare system than what is being attempted right now by the governments in terms of vaccine access. Greece also comes to mind. As I said, until a few years ago, migrants in Greece had access to a social security number and therefore access to healthcare, but that's changed. That's been rolled back. And yet, you know, as I said, and as comments have made, there are efforts ongoing in Greece to ensure broader access to the vaccine beyond what access to healthcare would allow. In Spain as well, as I mentioned, people who enter Spain for family reunification purposes are left out of the healthcare system. And yet in some discrete regions, you are seeing authorities trying to ensure that they at least get vaccinated. So in some states, indeed, countries are going further. I presume this is because of this, you know, incredibly important public health goal that governments have in mind. But I still think the generalization is correct, that, you know, access to the vaccine and the way that the systems have been set up in allowing access to the vaccine is generally reflective of broader healthcare access.
Thank you, Belkis. Do either you, Johanna or Karen, want to say a sentence or two about the intersectionality point?
What I can say is that I think what we need to do now is really collect all the data we have about the groups that were harder to reach and the different profiles, because sometimes it's really difficult to, like, also when it came to people that were hospitalized with COVID, it was quite sensitive to collect information also on those profiles. But we do think that it's important to know who is most affected by COVID, to know, which groups are harder to reach, and we do plan to look into how we can draw lessons from this towards the future. But I think that that's a good point to raise, that the data is often incomplete.
Yes, thanks a lot for that. And thanks for the question, Akram. I think it's a really, really important one and to keep in mind as we go forward. So a really warm thank you to all of the panelists on the first panel, all of our speakers, for those insights, for really laying a strong foundation for us to move into our next discussion. Our next panel is turning towards next steps. So where do we go from here? And what are the suggestions for actions for member states and also for the EU? So we have some wonderful speakers on this panel as well. And I will introduce our first speaker, who is John Kinsman. John is an expert on social and behavioral change and communication at the European Centers for Disease Prevention and Control. And I should say this panel will be a little bit more dynamic. We'll have some shorter inputs from our speakers and then open it up for some questions from all of you after they've each given their inputs. But the question really that we're going to put to John is, what does the ECDC's main work and findings tell us in terms of the state of play on the COVID-19 vaccine distribution through an equity lens? And maybe then, in particular, what are the ECDC's proposals to member states, your suggestions to member states about how to better promote equitable access to the vaccine? John?
Thank you very much indeed. Thanks, Selena, and for the invitation and the opportunity to take part. I've got some slides here, which Philippe is kindly putting up for me. And what I'm going to do is actually present some suggestions that were given to us during a webinar last week, in fact, at which Alina also presented extremely nicely. So this was a webinar at which we were looking at equitable access to COVID-19 vaccines. So next slide, please. This is, I think we know the basics here. The issue, which is through the whole pandemic, people who have been socially vulnerable they've borne the brunt, a disproportionate brunt of the impact of restrictive interventions that have been imposed upon all of us. We know that. And we also know now there is data that socially vulnerable populations are falling behind in terms of uptake. Not as much data as we would want, but it is clearly happening. So once again, those who have less and less because of what's going on. And that's the sort of principle we've started off here. So we had this exchange last week at which we brought together member states and civil society groups to discuss what good practices have been going on. And the principle we've worked under is nobody is safe until everybody is safe. Next slide, please. So it was a long 3-hour discussion, lots of interesting things came up. But when we sort of synthesized everything down, we came up with essentially 7 core suggestions, which now they're quite high level in the sense that they're relatively generic. And some of the points have already been touched upon in detail by the previous panel. So it'll be familiar for sure. But I think it's useful in the sense that it puts a lot of experience and wisdom from a lot of different people into one package. And so therefore we can see, as I say, at quite a high level, some of the things that we might want to be looking at. The first point here is probably the most difficult of all. What are the causes of inequalities in the first place? That's something that is a very long-term issue that takes a lot of political will from everybody. I think what we've seen is that all of these different vulnerabilities are ultimately socially determined. These are things that can be fixed if there's a will to fix them, and if there are ways people, as the Belgian speaker talked about, the very interesting creative ways that civil society is using. Of course, there's no one size fits all, and I should emphasize that our webinar was looking at many different types of vulnerable populations. There was a general focus on migrants and people experiencing homelessness, but we also had strong input from people with disabilities and people selling sex and other areas, also other people who have different issues which make them socially vulnerable. So ultimately, what are the causes of inequalities? Big picture, upstream thinking, very challenging. More immediately, we need to seize the moment. It's very clear that a lot of things have happened recently, but we need to think about now. We need to think carefully how we can learn the lessons that we have experienced over the last year or so, and how can we institutionalize those things now? How can we integrate these innovations now into public health systems? Because all being well, the most acute phase of the pandemic, at least in the EU, is now past. We will, of course, have more cases. We will have more waves, but let's just assume that the worst is over. Interest will wane. Other political things will take priority. So we need to seize the moment now and make sure that we get these things really, really incorporated into daily practice. Next slide, please. These two really go together to do with strengthening partnerships between public health and community organizations, and more generally, strengthening community engagement. We heard some very interesting input from colleagues who said that particularly at the beginning of the pandemic, the collaboration between some public health agencies and their own networks was very poor. There was not interest in actually reaching out and working with the people who are connected on the ground with the target populations. However, that said, things have improved substantially, and I think this is also an experience that is reflected in many areas of the response. We were all struggling at the beginning. We've all been learning lessons as we've gone along, and in many respects, things have got better. But so that's in terms of the relationships between the agencies and civil society, but also reaching to the actual people who we're looking at, the actual migrants, the actual people experiencing homelessness. We need to listen to them, engage with them directly. We need to make sure that we're developing trust, and we need to make sure that whatever risk communication strategies we have and develop and disseminate are tailored for the different groups, and critically that they're culturally competent. In other words, this really requires listening and engaging in the proper way. Next slide, please. This slide concerns issues that we've already touched upon quite a lot in the previous few speakers, to do with registration, people without social security numbers, to do with firewalls and things like that. So these are a lot of very practical things, which you can see. I mean, even these issues they're politically hot, difficult, challenging, but there are also things that you can do that aren't so challenging. The drop-in centres without appointment, single-dose vaccines, and so on. Next, please. And in terms of actually doing research, we must close the data. Very challenging. When coverage data is not stratified, the people who we're trying to support are essentially invisible. It's very, very difficult. But we know that actually collecting disaggregated vaccination data and integrating it into health information systems is really difficult. We've got methodological challenges, we've got legal challenges, we've got definitions, who are the people that we're trying to deal with, and the fact that also migrants, for example, are extremely heterogeneous. So very, very difficult to do that, but efforts must be made and continue on that basis. And also we must finally evaluate what we're doing. We must find out what works and what doesn't work. This doesn't mean randomized control trials. It doesn't mean doing serious high-level academic scientific studies. It's also important to evaluate and document process. We need to speak to the providers, we need to speak to the recipients, we need to collect quantitative data, and we need to collect qualitative data. And that's something which I can't stress enough. We need to document the lessons learned, and we need to share them. Thank you very much.
Thanks a lot, John, for really distilling down the very rich discussion from last Wednesday. And I think it's already very, very positive that the ECDC convened that meeting to have that conversation and to promote exchange. And then that you're clearly paying attention to the inputs that were given by the variety of actors who were there. Yeah, so I think that's wonderful and positive already. And we know that you also at the ECDC published a report earlier this month, specifically looking at improving vaccine uptake for migrants. And many of the recommendations there, the considerations put to member states echo what we've heard, I think, from our speakers now and what in your slides. So we'll come back to you with some questions in a moment. But first, we're going to turn to our second panelist, Yanis. Yanis Matsis is Policy Manager for Universal Access to Healthcare at EPHA, the European Public Health Alliance. And we're going to hear his insight on the question of really what are civil society's demands in terms of what the EU can do. So we've heard what member states can do. What can the EU do to really leverage the power that it does have to really promote more equitable access to the vaccine? Yeah.
Thank you, Alina. It's a pleasure to co-organize this event. I think it is a very timely discussion. This is the time to discuss all of these topics and to put these topics on the very top of the agenda. At EPHA, the European Public Health Alliance, with our membership, since earlier this year, I would say since January, we identified the question of equity in Europe within EU member states as a key topic that we need to bring to the center stage of the discussions. Of course, Brussels, the European Commission, with the EU member states have played the key role in providing the vaccines, right? It is thanks to the EU vaccine strategy, the joint procurement initiative of the European Union, that citizens across the EU had more or less simultaneous access to the vaccines. The EU vaccine strategy itself, actually the communication that the European Commission put out last October, identified vulnerable groups, disadvantaged groups, as priority groups, as groups that should be included and prioritized within by member states within the national vaccination plans. At EPHA, the European Public Health Alliance, the leading public health stakeholder here in Brussels, thanks to our members, we have members, for instance, today we're talking about the challenges that homeless people experience, and the one-stop shop, the organization that you need to consult is an EPHA member, FEANSA, the European Federation working with national organizations, working with and for people with experiencing homelessness, as well as other members. We hear from our members, patient groups, NGOs, human rights organizations, the challenges and the ever-evolving, I would say, priorities over the past 6 months by member states within the national vaccination plans. The national vaccination priorities, the guidelines, keep changing, as we've seen. All you need to do is simply read the news every given day and see how the rollout has unfolded in different member states. And the Commission has therefore played a very crucial role. It is thanks, as I said, thanks to the EU, and of course at EPHA we have applauded the EU vaccine strategy with all of its shortcomings, but overall, I think we are much better off having the vaccines, the doses available across the EU. But it is also the time to talk about the inclusion and the prioritization and to turn this into a concrete reality before it is too late for vulnerable groups to be prioritized and included in the national vaccination plans. So what did we do? We thought that it would be very important to mainstream this issue. And this is why we joined forces with PICUM, we joined forces with the European Patients Forum, with the European Disability Forum to look at not only the homeless and not only, of course, people with irregular status like refugees, undocumented migrants, etc., but the broad range of vulnerable populations and to bring the needs of these groups center stage to the political agenda. And this is why we sent a letter to the three commissioners, Commissioner Dalli, Commissioner Smith, and of course, the Health Commissioner, saying that there is a role for the EU to play in working with member states in truly, as John and others, previous speakers have already mentioned, they need to really work and take advantage, benefit from the expertise and the knowledge that civil society organizations and community-based organizations bring. We've heard already by previous speakers, also in Belgium, in Germany, but from the experience of the ECDC, that these organizations like ours, can be a partner to bring the expertise and the experience from the ground so as to make sure that we reach these populations, these, as the ECDC calls them, the hard to reach, these advantaged populations, and to highlight the risks also that these populations face, these communities, these people face, and to see how we can have these, again, as I said, tailored approaches in order to what? To achieve, obviously, increase the uptake of vaccines, counter vaccine hesitancy, and boost confidence in vaccines, obviously, and make sure that this equity that we keep talking about, not only when it comes to vaccines, but use this, as John rightly said before, seize the momentum to really look at how can we bring about long-term, long-lasting, permanent social positive change. Use for instance, the national vaccination plans, try to get them right in order to counter long-standing barriers. Because Alina, let's be honest. I mean, these groups have been facing challenges long before this pandemic. And of course, let's use this, obviously, this unprecedented health crisis and this tragedy that we're experiencing. Let's try to at least see how can we really address some long-standing issues, fix them possibly, use, as John rightly said before, some innovative thinking. And I think we've been seeing a lot over the past 6 months as the number of doses increased across EU member states. We've been seeing some innovative approaches. Also, Karen mentioned some of those in Belgium, but not only in Belgium, and how these synergies can be really taken advantage of or used to the maximum, like working with civil society organizations. And at the same time, as a Brussels-based advocacy organization at EPHA, we see there is a political momentum as well, right? I mean, as we speak, the Council, the member states are negotiating a new mandate for the ECDC. I think the ECDC has done a lot of impressive work along with the EMA and other EU agencies. With, of course, in these circumstances, we can always find some flaws. But we believe, and this is why we sent a letter to Andrea Ammon, the ECDC Executive Director, asking for the ECDC to have more of a say to monitor health inequities, to develop equity-related indicators. This is a good opportunity. This is the kind of momentum that we need to seize in order to bring about long-term, permanent, positive social change. Develop these equity-related indicators, work with member states to get this kind of data. I think the question of data has already been highlighted by my previous fellow speakers, and see how can we really boost the mandate of the ECDC, in order to, how can the agency itself contribute to the question of equity in the years to come beyond the current pandemic. Of course, this is not an ideological issue. This is not a political issue. For us as a public health organization, obviously public health means health for all, and good public health means good human rights, means respect for human rights and for social justice and cohesion. And these are not cliches. These are very pertinent, because at the end of the day, I think also Andrea Ammon has said it recently, nobody is safe until we're all safe. And this is the time to have this discussion, because we see, read the news, the variants, the boosters, the need for additional doses, etc., etc. This is not something that we're going to be done with in the coming weeks, let alone months. Therefore, this is why I think, and this is why as IPHA, we're joining forces with you and with obviously Doctors of the World and Human Rights Watch to have this very timely discussion. This is the time to discuss about these things and to bring about real changes. Thank you very much.
Thank you very much for that, Janis, your impassioned perspectives, which I think are very much bang on. And we're very, very happy to have with us our next speaker, who I think can maybe answer some of those points, pick up on some of those points. Our next speaker is Isabel de la Mata. Isabel is Principal Advisor for Health and Crisis Management at DG Santé, so the Director General for Health within the European Commission. Isabel, we're really grateful for your presence today. And really very eager to hear your perspectives. We know you have really an excellent insight on what is happening with regard to the pandemic, and an excellent insight on the European Commission's activities and priorities and role in this context. And it would be great to hear from you, Isabel, about what the Commission's response and role has been until now. In terms of the COVID-19 vaccine, but specifically around these questions of equitable access to the vaccine. Isabel, please.
Thank you very much, Alina. And good morning. So this commission, in the beginning, made clear that equality was one of the main topic and main action. And since 2 years ago, when this commission began, European Commission Task Force for Equality was created with a chair at the very high level in the Commission, where all the services and also some of the EU agencies are meeting and discussing and taking action for the different strategies. Have been approved strategies for gender equality, disability, Roma, migrant integration, and a series of different strategies, child rights. So taking into account all the different potential vulnerable groups and in all of those strategies, there is always a space santé, health. So with the commitments and also with actions that we are going to develop. It's true that you know that the competence are shared with the member states. So what we can initiate are the lead and making some action or putting together some ideas that then we will try to develop with the member state. And our main way to develop this with the member state, well, we have two. One that is the health program, that is the new EU for Health that is developing, our ideas, putting money on that and developing the actions, but also the steering group on promotion and prevention that is deciding with member states which best practices we are going to support, and that, can be shared, the experiences as today have been shared by Germany and Belgium, and good examples that we could be taken by other member states. We have also the health policy platform, as you know, where it's a space for exchange of among stakeholders and with the stakeholders and the Commission. Where now we are developing the thematic network for 2021. And I am mentioning this because there are 5 semi-finalists, and one of these 5 semi-finalists that we need to choose, you need to choose 3 because we cannot vote, they are the stakeholders. One of them is about the migrant and ethnic minorities and everything around that. At this moment, it's not the most voted network, so I encourage you to do that. This is led by EPHA. But there are others. I mean, I don't want to diminish the other 4 competitors that are quite interested. But just to tell you that there are activities that the Commission is undertaking. Regarding the vaccination, since the first moment in the strategy for vaccination, we mentioned the vulnerable population, and we have been working with the member state to introduce the specific program that have been developed at national level, this vulnerable population. So we have encouraged, I mean, the most vulnerable population at the beginning for the COVID-19 was the elderly, that was the first to be vaccinated. But we have always insisted in the closed settings, being that long-term care facilities, but also prisons or reception camps or others. Also for the homeless, we have insisted that they are usually a forgotten population that nobody take care, and some member states have taken the decision to vaccinate with the Janssen vaccine because only requiring 1 dose is easier to target those people. So the migrants is also one of the undocumented migrants, one of the classic population that sometimes are not tackled by the vaccination strategy of the member state. I mean, it's, in a way, if I can say, it's normal that you forget when you are planning whatever plan, including the vaccination plan, the one that you don't count on, the one that you have not registered. So it's call to remember about those non-registered population that, as has been mentioned many times today, we are not safe until everybody is safe. And it's clear that we have seen some outbreaks of COVID-19 cases in a specific population that is worse, is more difficult to tackle when we have already that prevent through the vaccination. I think that now we are in a moment where an important percentage of population has been already vaccinated, that we need to make the extra effort to tackle all of them that they are not yet vaccinated, and that I mean, are vulnerable population that now maybe we have more time to dedicate to look for those people, to look for those populations. Hesitancy is something important that has also been mentioned. We have been working since the beginning in hesitancy against the vaccine, because we were already working from 3 years or 4 years already on that for regular vaccination. And we have been doing the studies about who are the more hesitant. And in a way, we have found that for COVID-19, the more hesitant are the opposite to the regular hesitant for other vaccines. I mean, usually hesitancy is not going with the education. I mean, the less educated are the less hesitant people in general for all the regular vaccines. And here is the opposite. And also something curious that usually the less hesitant are the women, and now being female are the most hesitant. We don't know yet why this is happening, but these are the results that we are having. So and we know that there are a lot of women and less educated among the vulnerable population, and we need to focus on that, trying to fight hesitancy. I mean, with the lots of advertising, if I can say, the lot of talks that we have dedicated to the COVID-19 and the vaccine and the need to vaccinate, that still we have focus of pro-vaccines among the population is something that is worrying us a lot. Another population that is hesitant are the young people. That is, I mean, according to what happened for other vaccines. So we know they are invincible and they are not going to be touched by any disease, and it's more difficult to go with them. But I mean, we are taking this into account. We continue. We have been working with the ECDC. We participated in the meeting that they organized the other day. 3 new projects from the EU for Health program were initiated in the 1st of May for increasing vaccination, including COVID-19 vaccination in vulnerable population. One of them is specific for newly arrived migrants. The others are more general. And one is quite focused on prisons. So we are trying to I mean, even if, as I said, we don't have the pure competence, we have shared competence to set by the example and to put always in the stage, and that the vulnerable population, whatever the kind of vulnerable population, the ones that have a reason to have less access to health, less access to education, less access to COVID-19 vaccination, that they are not forgotten and they are given the possibility of being vaccinated, because otherwise, if we vaccinate 100% of the population that is easy to access, but we forget the ones that are forgotten, we will not have a way out of this pandemic, because there will be a pocket of unvaccinated people that will go on and go on and go on with the disease. Thank you very much.
Thank you so much, Isabel. And I think it's very much appreciated. You've ended with this point about, like, this is obviously about human rights and about equal protection for everyone in the population from the infection. But this is also just about the effectiveness of the vaccination programs. So we cannot really achieve our goals in terms of the vaccination programs if there are pockets of our societies, of our communities, that just cannot get vaccinated. So this is a very concrete and urgent dilemma that we need to find solutions to. So I think that's important that you've emphasized that. I think it's also very interesting that you started out by talking about the task force on equality under Commissioner Dalli, on the various EC strategies. So we now have, we're now going to hear any questions that we have from our participants. But maybe while we're waiting for folks to warm up to some questions, thank you, Isabel, for sharing the link to the European Health Policy Platform. Urge everyone to go and vote. I should note that you do have to already be registered to the platform to be able to vote. So I also urge you to register if you haven't already, so that you can participate in the platform and the various initiatives around the platform. So thanks for sharing that. So maybe I'll kick things off while we wait for, oh, here's a question. Okay, so our question it has to do with undocumented people and the vaccination, and concerns around anti-migration policies and sentiments in the EU that create a kind of toxic debate that where public health imperatives kind of push up against kind of the more toxic ways in which we speak about and create policies around undocumented migrants. So the question that is, what strategies can public health actors and civil society develop to reframe the debate? And then for you, I think, Isabel, in terms of the ECDC's recommendations from the recent report, could the Commission promote best practices among member states, given its role? So what can be the Commission's role in maybe having a bigger voice in promoting these existing best practices and recommendations? Can you comment on that, Isabel?
I mean, the role is of the Commission is to disseminate the idea of the importance. I think that this is also important. In spite of the anti-migration sentiment, as it said, or whatever, we have been always trying to differentiate, and even if, I mean, some of you are not going to agree with me, I know, but we are trying to differentiate what is healthcare from public health, and always passing the idea that public health, that is untouchable. So whatever you want to the policies that you want to put in place for your undocumented migrants, I mean, we are always talking about the undocumented or irregular migrants. Public health is for the well-being of everybody. So even if in a selfish policy, you should allow the access to public health services for everybody, register, irregular, regular, whatever. So, and those services are the preventive services, so including the vaccination. So the next step is the healthcare, okay, but if you don't want to go to the next step, even if also in a selfish policy, you should go for that. But okay, at least the public health is for everybody. So this is the message that has been passing forever, I think. And there was even a time where public health services were differentiated of healthcare services, and nobody was requested anything before going to the STI clinics or the vaccination clinics or whatever. So I think that also, I understand the importance of collecting information, but sometimes this collection of information is a barrier for people to go to the services when they think that they are going to request to be requested some information that they don't want to provide, or that they are afraid that if they are going to provide, they are going to have negative effects. So. We depend for the best practice sharing of the priorities of the member state. The member state select every year 5. One is different from the platform issue. So what the only thing that we can do, and that we do always, is to promote some of the best practices that take into account the vulnerable populations, and also some years there are things that are more popular than others. This year, vaccination is quite popular, so it should be no difficult to introduce some of them. But it depends on the member state. The only thing that we can do, is to encourage to take into account this issue. We are going to introduce also in the annual work program 2020. No, we have already in the 21, but we will do also in the 22 some more work on vaccination, and that one part could be dedicated to vulnerable population. Thank you.
Thank you, Isabel. And now, can I, while we're waiting to see if any participants have questions, if I can ask you briefly to say a few words, John. As Yannis mentioned earlier, there are negotiations underway to potentially augment the role of the ECDC in the context of health emergencies. Can you comment just in a few sentences, John, in our remaining time, on your thoughts about the ECDC's potential role going forward in terms of monitoring equity-related dimensions of health emergencies, and what else what more, if we were to give the ECDC more power, what more could the ECDC do around these issues of health equity going forward?
Thanks. Yeah, it's a really, really difficult, really important question. The new mandate is the discussions around it are underway, and it obviously is in the center of that whole discussion. So you would know more, Isabel, than I do. But I do know that there have been certain ideas laid down. They're still subject to discussion and debate. So something at some stage will happen. We don't know what, and it's a political process that's underway with the governments and with the Commission. And in terms of specifically the data collection issue, obviously this is where ECDC has a real role to play, because we do have what we call national focal points within every member state that we can approach on different specific issues with requests for information about different aspects, and whether that's we're talking about laboratories or whether we're talking about the epidemiology or surveillance issues or anything else that's going on. We have these so-called NFPs in every member state, and we request information from them on a regular basis. But the challenge, of course, especially in a time like this, is that we need information in order to have a big picture of what's going on. And we're asking a lot of the people, a lot from the people to give us that information. And there is, to some extent, what you could talk about as a sort of survey fatigue. There's, very often you say, well, why can't we get this information? Yes, but then someone in the member state has to actually give that information. They've got to put it together, collate it, manageable for us or whoever. And that's a really big challenge, and especially for the smaller countries. If it's a big country, they probably have the resources much more to hand. But in a small country where you have very few people working within that sort of forum, it's an extra burden, and it's not always necessarily very helpful for them to have to do that. So this is a really big challenge. We have to get this balance right. We need the data, but we can't overburden the member states. And that's why in my slide there, when we're talking about filling the data gap, it's such an important question, but there are so many challenges inherent in doing that, not only methodological and technical in terms of linking up health data with the standard routine health information system, but it's also just getting the data. I wish I could wave a magic wand and make it easy, but it's just really, really challenging. So clearly this is something we would like to see happening. I would never dream of making any promises that this will happen, because it's sort of, these discussions take place at another level. But obviously we're aware of it, we understand the need, and rest assured we do everything we possibly can to make the best we can of it. But do bear in mind, when we say let's just get more data, someone's got to put that data together. They've got to collect it, put it together, and make it workable for us. And that's a task not to be underestimated. So I'm not sure that's a very satisfactory answer, but I hope it gives something there. Isabel, you may want to add something on that. I'm not sure.
I mean, just that, yeah, as you have said at the beginning, the discussion of the new mandate of the ECDC is still on discussion. I mean, we hope that will be approved by the two co-legislators at the end of the year, but we don't know. But the main activity of the ECDC is not to collect information, is a different one, and there are at this moment other means that will allow for the European Commission, the European Union to do that, including all the work that is ongoing on the European health data space. So let's see what is possible, what is feasible, but take into account that the mandate of the ECDC cannot be modified just I mean outside of the place where it is ongoing now. So any pressure, any lobby, if I can say like that, you don't have to do with Andrea Monde. You need to do with the Parliament and with the Council, that are the ones that are decided the mandate of the ECDC for the next years. Thank you.
Thank you very much, Isabel and John, for those reflections. We're going to turn in a moment to our closing, which will be done by Michelle Lavoie, the director of PICA. But I do, on this panel, want to give 30 seconds to you, Yanis, for the last word on how the European Union can work better with civil society.
Yes, thank you. Well, I mean, we need more resources, more manpower, more staff, and money to be given to the ECDC. I agree with Isabel that this is still ongoing. I mean, it seems that the conclusion of the mandate will lead to the ECDC being able to move beyond guidance development and even issue recommendations. Of course, that remains to be confirmed. We will see. But I agree that there is a lot of potential there. For the message to the Commission would be, take advantage of what is given to you in the sense of the expertise, the experience that CSOs have already, foster and create the conditions for a sustained, structured policy dialogue with NGOs, with civil society organizations, with community-based organizations, so that we can discuss and brainstorm together and agree on even developing best practices, not only sharing existing practices, but also shaping those best practices from now onwards. And that would be my message to the Commission from now on. Thank you, Alina.
Well done. Very concise and to the point, Yanis, as always. And thank you very much to our panelists on the second session. Very grateful for your participation and for your insights. And I'm now going to turn it over to Michelle Lavoie, our director of PICA. Please stay with us for her final closing words. Thank you all. Over to you, Michelle.
Thanks so much, Alina, and to everyone for your excellent input. It's been very rich. I know we have just a couple minutes left, and I wanted to highlight 4 points as kind of maybe a synthesis, but also some takeaways, how we can move forward with this. So the first one is basically around research and data. I thought that it was really nice to see on John's slide work towards closing the data gap, which is definitely part of the situation. We need to know kind of what we're talking about, and I think in terms of access to the COVID vaccine, PICM has been looking for the past 6 months, kind of doing an informal mapping and also talking a lot to journalists about it in order to bring in more of a communications perspective on this. We will next week have the Human Rights Watch report, which we're very much looking forward to because it's been an in-depth look at a lot of the problems. It was very interesting at the beginning to hear Belkis's overview and to hear about all of these countries. I think you had mentioned 7, if I remember correctly, Belkis, where there are, in a sense, processes in place, but a lot of them have problems with just this registration number or some of the admin problems. So this is only possible once you're exploring it and doing an in-depth analysis. And we do have also the ECDC report on vaccines and migrants and their access. So all of this is really crucial in order to kind of understand what the issue is, how access to the COVID vaccine also compares to the situation prior to the COVID pandemic in terms of difficulties that homeless people and undocumented migrants in particular would have to access. The second point, when we have to look at the COVID vaccine and access to homeless and undocumented to it, is especially for undocumented migrants, none of this is possible unless there's a firewall. Undocumented people will not go to register for anything if they think that they will be deported, if they think that their personal data will be transmitted to the immigration authorities just because they're trying to get a free vaccine. And even in Germany, it's not entirely free, which is also quite surprising to see from some of this research that even undocumented still might have to pay some to get it. But basically, the firewall is primordial. And I think the 2 examples that we really should highlight are the city of Munich, which Joanna said has done a written confirmation that there will be a firewall, and the Belgian federal government. Which Karen said has an agreement on the firewall. And I think also interesting for us to know within PICM, we were also looking to government responses last year during the pandemic. And we saw that Ireland did install a firewall for undocumented people during the pandemic last year to be able to get access to health services. And Portugal also did a regularization, also to enable people to get more safe access to health services. We haven't looked at Ireland and Portugal as much in depth now in the vaccine, but it's interesting to know even in the first kind of phase last year in the pandemic, which countries were also looking and trying to establish firewalls. The third point is good practices. Here, I think we can definitely thank Karen for this very interesting approach that she described that the Belgian government is doing as an example, I think, to look at more in depth and see how other countries are doing it, but also to use the Belgian example a little bit more. She talked about a localized approach, outreach teams, mobile units, favoring the one-shot Johnson & Johnson vaccine instead of the other ones because it's more easier to reach people just once. They don't have to repeat the follow-up, etc. And especially working with civil societies to reach hard-to-reach groups, but also enabling and this also builds on what Yanis was saying at the end, enabling an ongoing discussion and dialogue with civil societies to help shape policies. So not just to share policies that governments develop, but help shape the policies. And it was mentioned that civil society had actually done a lot of outreach to the Belgian government in the beginning, and that actually helped the Belgian government develop its own policy to really, in our experience also within PICM, what we've observed is it is one of the more recognized ones in terms of really trying to be very specific about reaching vulnerable groups. And the fourth point is now the EU level. I thought it was really nice to see also on John's slide, using innovative thinking, seizing the moment. Yanis had also talked about bringing long-lasting change and countering long-standing barriers for vulnerable groups. if there was ever a moment, it most likely is now. We have a public health emergency, and obviously what we're talking about in the vaccine, it is public health, but this is a part of a broader discussion about access to healthcare more generally for vulnerable groups. There were various recommendations that were given, and some of them we've talked about now at the end. But I think that also it's interesting to look more in depth at the ECDC's slides and the results of that conference last week, which actually synthesized a very rich discussion from many different actors, working with migrants, homeless, etc., but on vulnerable groups. There was a recommendation that we could maybe potentially have guidelines from the European Commission on how to reach vulnerable groups. It was also recommended that the Fundamental Rights Agency could be working on such guidelines. The Commission could work together, but this would also be something that should be considered. If the Fundamental Rights Agency should also be involved in that and in having guidelines. We've heard a little bit about the ECDC's new mandate and also the possibility that there could be equity-related indicators. Also challenges perhaps in gathering data, as John was mentioning. How can you actually gather it, analyze it? How is that done without burdening member states? But this is also something to be looking into. There is the need also for not only exchanging good practices amongst member states, and the Commission could play a role in this, but as mentioned at the end, the Commission could also incentivize and work with civil society to also help develop these good practices and then exchange on them. And I think in general, more visibility at the EU level, building on the EU's 2020, October 2020 vaccine strategy, and the mention already there that there's a need to look at vulnerable groups. We could also have some more visibility now from key commissioners building on this joint letter that was sent. More visible statements, for example, on the need to really have more outreach towards these vulnerable groups, homeless, undocumented migrants, and any others. And just to say a final word, Isabel had mentioned in the beginning of her presentation that there's several EU strategies that now, in a sense, have a health component to them. This could also be a way forward, even on this vaccine, the COVID vaccine. There's now, and it was mentioned in the chat at the end, there's a European Pillar of Social Rights, there's a social scoreboard. This could be a way perhaps to get more focus on the COVID vaccine and on the vulnerable groups. There's the newly adopted child guarantee. Undocumented migrant children are specifically mentioned there as a priority group, homeless children as well. There's the gender strategy of the EU and the anti-racism action plan. So all potential avenues where we could try to pick up some of these areas that we've been discussing here and the challenges that member states face and really implementing inclusive strategies. So we would like to very much thank all of you for, once again, the speakers for participating, for all of the participants, for your interest, for your comments in the chat. We look forward to continuing the work together on this. Thank you.